And those of you who know me, as this will hint, a core interest of mine for, my God, 30 years has been ethics. And Azim and I agree that just as important as the technologic aspects, and I know, Abdullah, you agree with this, are the ethical dimensions. In fact, we're going to have a session in this program on ethical dimensions. And one aspect that's especially important for me in New York, and I believe here for you in Lebanon as well, is the expectation of perfection. And I want to start this off by a story by one of our most famous authors in the United States, Nathaniel Hawthorne. Some of you may know this name from his most famous story, The Scarlet Letter. Don't want to discuss this today, but one of his less famous stories is The Birthmark, that I think sets this up beautifully. Nathaniel Hawthorne was from the Northeast United States, New England, and he wrote about the most beautiful woman in the land. Not as beautiful as the women here in Lebanon, but beautiful for New England. Her name was Georgiana. And she was spectacular, but with one little blemish. She had a birthmark on her cheek. She fell in love with a scientist named Almar. And Almar was a scientist, and he was dedicated to perfection. And he made a concoction. He was brilliant. He had a great library for his day, and he did experiments, and he thought he had the perfect potion and that would cure the birthmark. And he did this on plants, and sure enough, he was ready to use this experiment on his beloved Georgiana. I think you can guess what happened. Georgiana wanted to make her beloved Almar happy. She drank the potion, and sure enough, the birthmark started to disappear. There was one minor side effect. Just as the birthmark disappeared, she died. It sounds corny, but it illustrates an important point. Perfection, whether we're in 19th century New England or 21st century New York City, Beirut, Zagreb, is not going to happen. And let's go through how we can have misconceptions, how we mislead our patients to thinking that we're perfect. And then I want to show how ethics has something to offer. Imaging. We've heard some presentations today from world authorities, Dr. Adra, Dr. Haddad, Dr. Kuryak, and I borrow some of his beautiful images that bring the fetus as a patient alive. And you can see this. You can see his images, beautiful images of normal, abnormal, of fetuses with personalities. They come to life. It doesn't take much imagination that women see these images and say, wait a minute, if we're able to see this, then we can see everything. And if something is missed, then the doctor made a mistake. The doctor did something wrong. Same as with genetics. With karyotypes or chorion-villus sampling, the report comes back normal or abnormal. And if the report is normal and there's something wrong, then someone made a mistake. Fetal treatment. Very, very rarely, there can be experimental fetal therapies that work wonders. And indeed, hospitals celebrate miracles in fetal therapies. But these are so few and far between. Patients think, well, if miracles can occur, why can't they happen for my child? The perinatologist made a mistake. Azim and I strongly believe there's good and bad in every culture. There's a lot good in the United States. There are many problems in the United States. The consumer rights movement, there's a lot good. The empowerment of women, but there's a lot bad with the empowerment of women. Later in this session, when I spoke to Professor Adra, we're going to talk about home birth and the problems with that, where women demand too much. And women have a demand. If something is wrong with the baby, the doctor made a mistake. Termination of pregnancy. Termination is an option in most countries throughout the world, here in Lebanon as well, based on respect for autonomy. We're going to discuss this, I think, tomorrow in our ethics session. But the women would suggest, if the doctor didn't offer this to me, then the doctor made a mistake. Prematurity in the obstetrics. We know here that Emil Papirnik made timeless contribution. Unfortunately, we lost Emil. One of my predecessors at Cornell, Fritz Fuchs, didn't make a timeless contribution with alcohol. The point is, Professor Koryak did an excellent conference a few years ago in Dubrovnik, Prematurity, the Unmet Challenge. It's still the greatest challenge for obstetrics today. Neonatologists have done so much better, but we need to remember that the perfect baby is not the perfect child, and morbidities, remember. And you can see how parents have the misperception that when there are disabilities that occur, someone made a mistake. I hope the American cancer that we have in America, the malpractice crisis, doesn't happen here in Lebanon. These mistakes translate to liability issues. But nonetheless, none of the advances in perinatal medicine alters two fundamental realities. The processes of conception, pregnancy, and birth are imperfect. We've come many miles, but we cannot perfect these processes. I want to present something and see if you agree. Ethics can anticipate the potential for conflict, and we're fortunate. In obstetrics, we have multiple visits with our patient so that we can anticipate this conflict. Now you may say, Frank, this sounds beautiful, but it's totally unrealistic. I want to suggest it isn't, and I want to give you some hard data that shows that it's very realistic. And I want to use the example of risk assessment, where there is some hard data. First, let me say, by giving informed consent, it doesn't mean you tell the patient everything. Some people say you tell the patient everything. This is ridiculous. Psychology has shown that if you give someone too much information, you impair autonomy, you don't enhance it. You have to make it manageable. The next point is that the age base of 35 years is an anachronism. It doesn't have a place today. You offer women this option. Some women are very religious, and please, there are many different religions. We respect religious values, and we don't push prenatal testing on them. Other women say 99% isn't good enough. I want an invasive test. Give it to them. Most women will have risk assessment, and I want to emphasize, when we introduce risk assessment, the rate of invasive testing goes down. Johnny Moni and the group from Sardinia was the first to show this. We've shown this. So we reduce the rate of invasive testing. It's only for a very small group in the middle that want additional testing. Okay, let me provide some hard data. This was done in conjunction with Kypros Nicolaides in Great Britain. This was a series of over 30,000 consecutive singleton pregnancies. They were counseled in a manner, and it proves that pregnant women can assimilate information if done realistically. This picture isn't worth 1,000 words, it's worth 1,000,000 words. The regression line is the risk of aneuploidy. The bars are how these 30,000 women sorted themselves and chose an invasive test. And what it suggests is that women make rational decisions if given information. It validates the concept that women can make reasonable decisions. This can work to prevent the misconception of the perfect baby. Early in pregnancy, or ideally preconception, anticipate the potential for conflict. Use the informed consent process to enhance the autonomy of the pregnant woman. And again, the great advantage we have in obstetrics, we see the woman over and over so we can reinforce these concepts. Preventive ethics provides pregnant women with a continuing, succinct education. This is a statement that we've published with my mentor, Robert Brent, one of the pioneers in teratology. And I want to read it, and I suggest whether it's New York City, Paris, Zagreb, or Beirut, this should be part of prenatal care that we tell all pregnant women. If you are healthy and have no personal or family history of reproductive or developmental defects, you begin pregnancy with a 3% risk of birth defects. And once you know you're pregnant and having missed your first menstrual period, you have a 15% risk of miscarriage. These are the background risks for all pregnant women. Every month, I meet with my medical students at Cornell, a different group of medical students. And it's fascinating for me when I ask them, what is your risk of having a child with a major malformation? And I get answers of 1 in 1,000. Our medical students don't know this. The women don't know this. They don't know that the risk is roughly the chance of a number coming up on a roulette wheel. I'm not supporting gambling, but this is everyone's risk. You decide to have a child, you're taking a risk. Women need to know this so that when something happens, they don't blame themselves, they don't blame us. Sounds so simple, but so important. When we talk about patient safety in this meeting, miscommunication is the greatest sin. Another source of miscommunication, when a defect occurs, what's the natural instinct? A woman wants to blame herself or blame the doctor. What is the truth today? 75%, we just don't know. Genetic etiologies, environmental concerns, infectious agents are a small minority, only 25%. So women think if I didn't have a glass of wine, or if I didn't have sex, or if I didn't drink paint fumes, I wouldn't have had a baby with a malformation. This is nonsense. They need to know this. It sounds so simple, but please be sensitive to this so you help your patient. And then they don't blame you that you did something wrong. Patients should be told that most anomalies are the result of unknown causes. If a birth defect does occur, neither the patient's behaviors nor the obstetric management is to blame. So simple, but so important. And when we talk about patient safety, so essential. One of the important themes of this meeting is prevention. The simple truth prevents many, many problems, both clinically and medical legally. While there have been great advances in prenatal diagnosis and therapy during the 50 years, and indeed some of the people in this room have been important parts of this, we don't have the capacity to diagnose or treat all anomalies. Perfection of pregnancy by perinatal medicine is not attainable now or even in the foreseeable future. Even Azam Kuryak is not perfect. The inherent errors, forgive me Azam, forgive me. Even the inherent, Berserker will support me on this. The inherent errors of human reproduction, the highly variable clinical outcomes of these errors, the limited capacity of perinatal medicine to detect these errors, the even more limited capacity of perinatal medicine to correct these errors. Not uncommonly, when I make a mistake with thy children, I tell them I'm not infallible. And they answer, we know you're not infallible. Some pregnant women may be influenced by the inappropriate expectation of perfection and believe that anything less is a disaster. If women push me for perfection, I say, look, if you want a guarantee, you can't have a child. Ultrasound and the wondrous things that can be done with 3D and 4D ultrasound can do so much, it cannot give a guarantee. You're going to worry about this child not only till the baby is born, but throughout the life of the child. If you believe in an afterlife, you're going to worry about the child after you go to the next world. I argue that preventive ethics is invaluable to anticipate conflict and prevent it. I'll close the way I began. I argue that Nathaniel Hawthorne, one of our great American authors, had a timeless truth here, arguing to pursue perfection is impossible. It's good that we do the best we can, and indeed, we've accomplished much, but to use a word that's rarely used in perinatal medicine, humility, is essential that we remember this, and our patients must recognize it. Thank you so much for the privilege of being with you.